Hello and welcome to another podcast. Today we're going to continue with medications and we're going to look at gentamicin. Now gentamicin is arguably one of our most complex antibiotics to administer in an emergency department and especially in the pre-hospital world that we like to work. So this presentation we'll be spending a bit of time talking about the pharmacology, but then we're going to spend a portion of the lesson looking at the administration considerations for gentamicin itself. So gentamicin is an aminoglycoside and it's a bactericidal against your gram-negative or your aerobic gram-negative bacteria. It's used in several infections, including one we use it for, which is sepsis or septicemia. It's also going to be used in meningitis, urinary tract infections, and things like that. It's a very versatile antibiotic that's often used in conjunction with other antibiotics like beta-lactams, but we'll talk more about that as we go on. We'll start with pharmacokinetics of the actual medication. Now, it's poorly absorbed in the gastrointestinal system, which is why you'll find it is predominantly given as a topical or intramuscular or intravenous injection. It has a very small therapeutic window, but its therapeutic actions are often associated with higher concentrations, which obviously means that large doses, molecular weight-wise, are needed to be given in order to have a therapeutic effects. But the dose needs to be weighed up, if you will, because the higher doses or continued administration of the actual antibiotic also has a higher risk of adverse effects that we'll talk about. So it's a very small window between that therapeutic effect and the safety range as well, which is why the dose can be quite difficult to get right. It luckily has poorly penetration ability in any of our central nervous system cells or general cells, mainly is due to the fact that it likes to sit around the extracellular fluid and partly binds to albumin. Its concentration in the extracellular fluid is why it has some of the effects it has, which is our nephrotoxic and ototoxic effects, but it's also why it can travel through the actual gram-negative bacteria membrane as well. Now, its metabolism is minimal. It doesn't actually change that much through metabolism, and a large portion of it is excreted unchanged in the kidneys, which leads to its nephrotoxicity nature because it can be found in the urinary concentration 100-fold higher than the serum. So it disperses itself around the blood quite at low levels because it moves to that extracellular space first before it becomes highly concentrated, if you will, around the kidneys and of course the ear as well, which we'll discuss. Now moving on to our pharmacodynamics, gentamicin being an aminoglycoside, it's bactericidal and it passes through the gram-negative membrane in an oxygen-dependent active transport. Now because this oxygen is required is why aminoglycosides in particular are not really effective against the anaerobic bacteria because they don't have those oxygen-dependent transport chains. Now once aminoglycosides or gentamicin moves into the cytoplasm, it binds to the 30S ribosome subunit, and that disturbs the messenger RNA translation, and thus it leads to the formation of a truncated or non-functioning protein. Now obviously this non-functioning protein goes on to affect the bacteria. Now the exact mechanism of what makes gentamicin bactericidal is not actually fully understood. The few theories is that this truncated protein will actually place itself in the cellular wall and compromise its permeability. So it would make it more permeable, which allows for an influx of fluid causing the cell to rupture itself. Now gentamicin, like all aminoglycosides, exhibit concentration-dependent killing as we spoke about. So the higher concentration correlates with greater antimicrobial killing. Now for these reasons, it's important that we monitor how much we're giving And if we need to give multiple doses, we do it at strict timings in order to maintain that serum level that's required. Okay, we've touched on a little bit of adverse effects as we've been going through, but we'll just focus on a little bit more with that. So characteristically speaking, gentamicin reaches very, very high concentrations in the renal cortex and in the inner ear because of that extracellular fluid gathering that we spoke about. Now, in the inner ear, it tends to lead to auditory and vestibular dysfunctions. Now, the first manifestation that generally occurs is cochlear damage, and that's generally associated with high-pitched tinnitus, which may last for a few weeks after gentamicin is stopped. Now, high-frequency hearing loss may be present in around 66% or 2/3 of patients receiving aminoglycosides and in particular gentamicin. But only a small percentage of those people will actually complain about hearing impairment because it's the higher pitch frequencies that are lost. Now, the vestibular toxicity originally manifests as your nausea and vomiting, which leads to one of the main side effects of gentamicin, but then it can go on to having balance disorders and vertigo within the first 2 weeks. Now, the chronic phase, which may persist for around 2 months or even for life, includes your ataxia and sometimes dysfunctions as well. Now, gentamicin is prone to accumulation around the renal areas as well, as we spoke about, which can lead to a reduction in the glomerulus filtration rate as well. Generally, about 14%, but as you can see, 10 to 25% of cases will have some disruption in the glomerulus filtration rate itself. Now, things that make it more likely to get adverse effects, we'll talk about that when we look at administration, but if somebody is dehydration or volume depleted, it does increase the likelihood of these adverse effects occurring. So you'll need to be aware, because if we're treating it for sepsis, you can bet your bottom dollar that they're going to be volume depleted and they're going to have potentially increased risks of adverse effects, which is why administration is so vital to get right. Now, when we look at contraindications for this, we have the general hypersensitivities as we do for everything, but there's also people that have previously had ototoxicities from aminoglycosides. They tend to be at higher risks of the higher end adverse effects the second time around. And obviously anyone that has renal impairment, you don't give gentamicin to. Okay, let's move on with dosage and administration factors. Now, to make this a little bit more complicated than it already is, it cannot be mixed with any cephalosporins or penicillins. Now, a lot of protocols, when you're using it as an adjunct, it's used as an adjunct with your beta-lactams, which is, of course, your cephalosporins and your penicillins. So you're allowed to give a beta-lactam and an aminoglycoside to a patient, but you're not allowed to push it in the same bag, obviously, and you also have to be really careful of pushing it into a line that contains that penicillin as well. So the penicillins and cephalosporins will actually weaken the effects of the aminoglycosides. So you'll push the penicillins, you'll flush, and then you'll push your aminoglycosides or your gentamicin in this case. Now, if you push it rapidly, you have an increased risk of ototoxicity, especially when you couple that with the volume depletion that we already spoke about. Now, dosage is not simple. It's IV, it's difficult to calculate, and it is always based on something known as ideal body weight or an adjusted body weight. And if you're working with a certain demographic, then you also have to factor in the glomerulus filtration rate as well. So let's spend a little bit of time talking about this ideal body weight. In order to calculate somebody's ideal body weight, you first of all have to know the patient's height and weight. Now, as you know, we don't go out with scales, and measuring someone's height is also difficult in the pre-hospital environment. So if you can't measure it, which is highly probable, the best point of call is to ask the patient. Most people have a general idea of how much they weigh, and worst case scenario is you guess, and if you have to guess, then you need to mention that to the medical officers before we're getting our permission to give gentamicin, because it may actually be decided to hold off gentamicin before we get to a facility that they can measure more accurately. Okay, but if you're guessing and they allow you to guess, always go a little bit lenient on the lighter end. Always make someone a little bit lighter than they actually are. Now, there are a bunch of charts available and guides for aiding in calculations. They generally do it as the 5 centimeter ruling as it goes along, but the equation for men and women when you're dealing with ideal body weight, you have the same height, starting height, which is 152 centimeters, and then you plus 0.9 kilograms for every centimeter over that. The only difference is men have a starting weight of 50 kilos and females have a starting weight of 45.5 kilos. So a male and a female that are both 152 centimeters, the male is only ideally able to be 4.5 kilos heavier than the female, which may come as a bit of a surprise to most of you. Now, going through a calculation, let's just say we have a male that weighs 98 kilos and is 175 centimeters tall. The first step we have to do is we have to figure out the height variable, okay, because then we know what to times it by. So 175 minus 152 equals 23 centimeters. Then we put that 23 centimeters in the equation, 50 kilos plus 0.9 times 23, 50 kilos plus 20.7, which will give us 71 kilos of ideal body weight. Now, if we do the exact same thing, surprisingly enough, 4.5, 5 kilos less, you'll get 66 kilos for the ideal body weight of a female. So that seems simple enough, and that's the calculation that you work with. If somebody weighs less than their ideal body weight, then you work with their body weight. If they don't, then you use their ideal body weight, unless their actual body weight is 20% greater than their ideal body weight. Which brings us up to the added complexity of the adjusted body weight. Now, as mentioned before, the adjusted body weight is calculated off somebody who is 20% greater than their ideal body weight. So, if we look at our male just before, we can see if we do a simple equation, which is body weight minus ideal body weight, divided by original body weight times 100 will give us our percentage gross of difference. So if they are 98 kilos and we minus their ideal body weight of 71 kilos, which is obviously 27 kilos, divided by 98 times 100 gives us a 27.5 percentage larger than they should be, which is over 20%, so we need to use the adjusted body weight. Now, the adjusted body weight is ideal body weight plus 40% of the difference between body weight and ideal body weight, which is 27. So in this case, it would be 71 plus 40% of 27, which is 71 plus 10.8, which gives us 82 kilos, which is the adjusted body weight. Now, most people, particularly males in the military, will be greater than 20% their ideal body weight. Okay, it's just anyone who's large, strong, big build is going to be 20% greater than their ideal body weight, because the ideal body weights are basically calculated on smaller framed people. Now, it doesn't necessarily correlate with the BMI, and it certainly doesn't correlate with fitness or general health. It's just got to do with mass and distribution of medication associated with safety. Okay, so that's why we're using this calculation. We're not finding those people that are obese and telling them to go on dietary plans. It's just giving them gentamicin at a regime that is both therapeutically useful and safer than if we were just to give it to actual body weight. Now, we'll finish up with a little bit of clinical take-homes. Once we get our number, our ideal body weight or adjusted body weight, it's just a matter of multiplying that by the required dose. Now, depending on the protocol you're using, the required dose is between 3 and 7 milligrams per kilo. So you calculate that, and then you round down to the nearest 40. Yep, nearest 40. Okay, you never round up, you always round down to the nearest 40 because the injections come in 80 milligrams in 2 mils. So 40 milligrams in 1 mil is what you do. And then you'll mix that in 20 mils. Sometimes says putting in a 100 ml bag is fine as well. That works. And you infuse that in a slow push or over 5 minutes. Either way, it's over 5 minutes, even if you're pushing it or if you're running a bag through. Okay. Now, as mentioned before, if they need a penicillin or a cephalosporin, you give that first, especially in sepsis. You want to give it quickly. You want to flush the line, and then you want to start with your gentamicin. If someone is dehydrated and you couple that with a rapid push, it will increase the risk of ototoxicity. And remember, 66% of patients already had high frequency hearing loss and tinnitus. Means it doesn't take much to tip them in to that permanent hearing loss or vestibulocochlear impairment as well. Okay, so always try to fix in sepsis, give fluid resuscitation as well, and then give the antibiotics in another line ideally, but if you have to, don't interrupt the fluid resuscitation for the administration of antibiotics, especially when you're dealing with gentamicin. Now, because sepsis and septic shock are quite difficult and statistically very rarely practiced, it's always something that we know can happen. We've all seen it in our career if you've hung around long enough. It's very, very, very common, but it's not often practiced. So in a pre-hospital environment, you've got a mixture of drugs, and those two that I've mentioned aren't even the extent of it, depending on what you're dealing with. You've got fluid resuscitation with very sick patients that you need to get right. So it's always recommended that you actually practice your septic shock protocols, get someone to run you through them, just to get a better understanding of what you're going to do and get comfortable with the mixing and calculating of pretty complex doses on the ground. Okay, so that is gentamicin in a nutshell. I hope you got something out of it and at least got the urge to maybe practice a little bit of calculations, and definitely make sure your calculator is up and running before going out in order to better and more safely administer gentamicin to patients that need it. Until next time, take care.